We understand that malaria is also amongst those diseases like HIV and TB that are affecting our region, and in most cases, when they're being addressed, it's like a combined thing to actually address malaria. So, Mr. Bongani, would you tell us more on how the burden of malaria was before the establishment of Elimination 8, and how the burden is now that we have established Elimination 8?
Thank you so much for the question about malaria and its trajectory from the 2000s till the establishment of the Elimination 8 in 2009, as the Dr. John has mentioned. Basically, we saw back in the 2000s a high number of cases of malaria in the region to the tune of about 14 million cases. You rightly mentioned that it is one of the major diseases comparative to HIV and TB, as it were. But there has been drastic declines owing to the great effort that countries individually have put together from the thinking and programs on control before now the advent of elimination and the Elimination 8, as it were. So basically we're seeing sharp declines in the 2005 going into 2010 to the tune of about 2 million cases for all 8 countries, which is not an easy task to actually achieve. So basically the frontline countries which Dr. John had mentioned, your Botswana, eSwatini, South Africa, and Namibia, actually then looked at means with which they can now scale up their efforts towards elimination, transitioning from control, which is high burden transmission, into elimination mode. That actually pushed countries to actually think and put elimination high up in the agenda. But be that as it may, you would realize that in the years 2016, we started seeing sudden increases. Now, our curve was going up in the region of malaria, and we were asking ourselves what could be influencing such increase. But we saw in 2017, the worst year in the region, where cases actually went up. Your countries such as Namibia and South Africa actually reported quite a high number of cases. But there is light at the end of the tunnel, if I may say, because 2018 showed us that after efforts by the collective effort of ministers of health to actually address the epidemics in the region, there was now a decline, a sharp curve decline in malaria in the region. But countries which are still high burden had flatlined, whereby there was continuous transmission, but there are still efforts in the second line countries of Angola, Mozambique, as it were, Zambia, Zimbabwe, which are doing very, very well with regards to controlling and maintaining and reducing mortality, as it were, due to malaria. But I wouldn't have done justice if I had mentioned what transpired after ministers of health in 2017 said, now that we're experiencing such unprecedented outbreaks, what are we doing about it? So they put together their efforts and established the E8 Situation Room. It's more like a war room in politics, where we come together and we talk about the situation that we're facing, what is being done, who is doing what, and we assign roles and responsibilities. Predominantly, it is a funding issue. Predominantly, it is a human resource issue. No one is there to do the work, be it nurses, be it response teams to epidemics. So ministers of health assigned programs in country together, coordinated at a central level to respond to epidemics during 2017. That is the reason why we saw that sharp decline that we experienced in 2018. And going into 2019, as we're in the middle of 2019, there is still observed declines in malaria in the region.
Thank you so much for that, Bongani. I think it all brings to the essence of having SADC member states integrating in the approach, which is actually a good thing, because we've also noticed that the decrease is about approximately 50%. So it's actually a huge decrease. So going back to the integrated approach in terms of the response to malaria, has there been any challenges in the response, and or you've only mentioned about the milestones, good thing, but I also want to know if there were challenges in the process in terms of responding to this burden.
So I'll start off by saying that unlike other diseases which have been eliminated or eradicated, as we use those words interchangeably, but they have different meanings, like polio, for instance, we do not currently have the smoking gun to actually eliminate malaria. We are using different tools, which to a large extent are quite old. They've been used since the 60s. I'm mentioning indoor residual spraying, which majority of the countries which have eliminated have used it before. We're still using it even to date. There hasn't been innovation such that we actually achieve one tool that can actually provide protection and protection from transmission. So in that case, that being said, those are the critical challenges at a bigger grand scheme of things, where we're looking at the very same old tools that we've been using, and the lack of new players or new tools that are being introduced. We are very much keen to see what will come out of the studies around vaccines for malaria. I think that is quite, it presents hope that to a large extent there will be a solution to this. But as you mentioned, the challenges, like I mentioned earlier on, the smoking gun we are still looking for, but we are putting all our efforts, the different interventions, and the community at the grassroots level, at the district level, the community owning up to interventions, owning up to your indoor residual spraying, owning up to the health messages that we send. I think that's the essence of primary health care, as it is about the people and their health at a local level, as it were. But mentioning some of the interventions that as the E8 have motivated for and looked into their impact, we're talking of border health posts. These are health facilities in far-flung areas where predominantly or to a large extent are not so much targeted by the conventional means or the conventional ministries and health services. So you find that those populations are not necessarily accessing healthcare, and they find that they actually travel distances to actually access testing and treatment, as it were. So border health posts in those border districts of the 8 countries have actually provided a bridge such that all those who are moving about in our borders, they are able to actually access healthcare. That has been the mainstay of and the biggest flagship program of the E8 since the beginning of 2016-2017 intervention. Dr. John, you might want to add on other interventions that we've actually deployed in the region.
Thank you so much. I think it's just to quickly add to the challenges that you have ably outlined. Just to add that part of the challenges that we have with regard to malaria elimination are things related to the weather. The environmental change that we are seeing has implications on transmission of malaria, where you might find transmission is going into places where it was not there before, just because of the change in the rainfall patterns, in the temperatures, in the humidity. So that is a key challenge that we need to pay attention to as we are trying to drive towards zero malaria. Then there is the issue of local resources. As you may realize that to try and run this last mile, we need to make sure that the third objective, which is maintaining and ensuring that we have sufficient resources to make sure that each country drives the last case of malaria down, we must rely on domestic resources. And I must say, politically, the politicians have committed very well to use local resources to do that, but to translate those commitments into action remains a challenge. And I think it's an opportunity on this platform for you to join this fight and the social movement of eliminating malaria, that domestic resources needs to come on board. To rely on donors to drive this local agenda, it's a bit dicey and risky. So I just wanted to add those two little challenges.
Oh, that's quite detailed. You